Hi guys, my name is Sanjay Gupta. I'm a consultant cardiologist in New York, and today I wanted to talk to you about strokes and particularly strokes in patients with atrial fibrillation. In this video, I'm hoping to talk to you about the different types of strokes, why strokes happen in atrial fibrillation, why it's important to be on anticoagulation or medications which stop your blood from thickening up, um, and also, I'm going to talk to you, talk a little bit about an interesting study which shows whether the amount of atrial fibrillation a person is having uh, um, can directly increase your chances of stroke. Okay. The first thing I wanted to say is today's the 16th of June. I am so grateful and so appreciative of all the really kind birthday messages that you've all sent to me. Thank you so much. I really appreciate it. I've had a great day, and I didn't want to go to bed tonight without talking to you and doing a little video. So here I am. All right. So the first thing to say is that a lot of people are terrified of developing atrial fibrillation. I speak to a lot of people who have ectopics, who have palpitations, and one of their biggest concerns is atrial fibrillation. So the first question to say is, well, why is atrial fibrillation such a big deal? And any condition can do two things to you. It can either affect your lifespan in some way, and secondly, it can affect your quality of life in some way. They are two very different things, okay? Your quality of life and your lifespan are two very separate things. And it's very important to make that distinction and understand that. I can feel great, but that does not necessarily mean that I'm going to live for a long time. Similarly, I can feel awful, and that doesn't necessarily mean that I would have a much shorter lifespan. For example, some people who are unfortunate enough to have brain tumors can have no symptoms whatsoever, but may not live for very long. Other patients can have migraines, which can be awful and can destroy their quality of life, but they can go on and have a completely normal lifespan. So in atrial fibrillation, when I talk about things, it's really important to draw that distinction between how it affects your lifespan and secondly, how it affects your quality of life. In terms of lifespan, the main risk with atrial fibrillation is that it increases the risk of strokes, and strokes can shorten a person's lifespan, in addition to also affecting their quality of life in the future, but they can shorten the lifespan. So the main risk of atrial fibrillation when it comes to lifespan is the risk of it causing strokes. In terms of quality of life, the main problem with atrial fibrillation is that it can cause symptoms. It can cause people to have palpitations. It can cause people to feel very tired. It can cause them to be breathless. And it can just generally really affect people's quality of life. But there are lots of people who have atrial fibrillation who lead a relatively normal quality of life. So it is not guaranteed that just because you develop atrial fibrillation, you will have a significantly worse quality of life. But some people undoubtedly do, and some people come to me and they don't even know that they're in atrial fibrillation. Today, I wanted to talk to you about atrial fibrillation and strokes because atrial fibrillation significantly increases the risk of strokes, okay? And before we talk about how strokes happen, before we talk about how strokes happen in atrial fibrillation, I wanted to talk to you about strokes in general so that you understand this. Basically, for a lot of people, stroke may be a concept that they don't understand, and I just wanted to run that past you. Number one, a stroke is when part of the brain, okay, brain tissue, which needs oxygen, doesn't get the oxygen. The oxygen is supplied by blood, and if the blood, for whatever reason, does not get to a part of the brain, then that part of the brain can get damaged, and that damage results in that part of the brain, whatever that controls, whether that controls muscle power in your arms and your legs. If you don't get oxygen there and that part of the brain dies, then you lose the power in the arm and the leg, for example. So a stroke is basically damage to the muscle, to the brain tissue, because it's not getting the blood it needs. There are two mechanisms by which that brain tissue will not get the blood it needs. One, if something stops the blood from getting to it, i.e., there's a blockage of some sort which stops the blood from getting there. Two, if the blood goes elsewhere, i.e., if there is a bleed, then the blood would bleed out rather than getting to that tissue. This is a very simplistic explanation, but those are the two mechanisms, okay? When the blood cannot get there because there's a blockage, that is called an ischemic stroke. When the blood bleeds out, and that's why it doesn't get to where it's supposed to go, that's called a hemorrhagic stroke. So it's just worth bearing that in mind. In people who have ischemic strokes, there are two mechanisms by which they can get something stopping the blood from getting to the vital tissue. The first is that if you have areas of furring up or narrowing due to long-term smoking, diabetes, high blood pressure, what can happen is you can get plaque built up. So you can get areas of furring up. And sometimes those areas can rupture, and suddenly a blood clot can form to try and minimize the bleeding around that ruptured area. And that forms a blood clot, and that blood clot stops blood from getting to the getting through to the vital tissues of the brain, and that causes a stroke. Another mechanism, okay, is that a clot can form somewhere else in the body, and that clot can get dislodged and go all the way up to the brain and then get stuck in a part of the brain vessel which is small enough and doesn't allow the clot to go through it. And thereby that area then gets blocked, and that part of the brain doesn't get the blood. In atrial fibrillation, most people believe that the mechanism of stroke is that a clot forms within the heart, and then that clot gets dislodged and goes to the brain. It is an embolism, i.e. the second type. It's not something that most people don't think that the strokes that people are predisposed to in atrial fibrillation, they don't think it's because they've got the plaque rupture that I described as the first type, but more so because it's this clot that is getting dislodged. Now, why does atrial fibrillation cause clot? Well, in atrial fibrillation, what happens is the heart does not pump as efficiently as it would if the patient was in a normal heart rhythm, okay? So the pumping ability, the efficiency goes down by about 15%. And for that reason, only 85% of the blood that would ordinarily get pumped out gets pumped out, which means around about 15% of the blood stays within the heart. And that 15% can stagnate because it's not moving as much, and it can then thicken and form clot. And then there is a theoretical risk that the bits of that clot can get dislodged, go to the brain, and cause the stroke. Okay, so that is the mechanism by which people with atrial fibrillation are thought to have strokes. And that is why they're put on anticoagulants, which are medications which stop their blood from thickening up, stop their blood from forming clot, and thereby minimizing the risk of strokes. Now, you may ask, well, if this is the only mechanism, if this is the mechanism, then surely by taking an anticoagulant, a medication which stops the blood from thickening up excessively, you would minimize the risk of stroke. Most studies have shown that the risk of stroke is reduced by about 64%, and only 64% when you take anticoagulants, okay? And the question is, well, why is it only 64%? Why is it not much higher if you are stopping the blood from clotting? And if that is the mechanism, then why not? Why is it much higher? And the answer to that is this, that these patients who have atrial fibrillation also have things like diabetes, high blood pressure, previous strokes, heart failure, vascular disease. Okay, vascular disease means furring up of heart arteries or leg arteries. So by very virtue, they may have some degree of furring up, and therefore these people can still have the first type of stroke I described, which is the ischemic stroke, where they may actually have plaque in their brain arteries and the plaque ruptures. So they may still have the stroke, but the stroke may not be because of the mechanism, the second mechanism, i.e. clot getting dislodged. Now, whilst anticoagulants are great for stopping clot from forming, they don't really do as much for the sudden plaque rupture that I've described. And this is why, despite good anticoagulation therapy, some people can still have strokes. And so the next question then to say is, well, how do you minimize the risk of stroke? Well, of course, it is important to take an anticoagulant if your risk of stroke is deemed high enough. And I'll talk you through how it is calculated. But more importantly, and undoubtedly very importantly, it is incredibly important to control risk factors for development of furring up of brain arteries, etc., i.e. stopping smoking, keeping diabetes and high blood pressure under control, keeping the cholesterol under control, and general good lifestyle measures like minimizing inflammation. How do you minimize inflammation? You eat healthy food. You sleep and get good quality, good volume sleep every day. You minimize stress, and you increase your exercise levels and take regular exercise. And those are the kind of things that you should do in addition to the anticoagulant that you take to minimize your risk of strokes. Because strokes in atrial fibrillation, although many of them are embolic, i.e. from the clot forming and getting dislodged to the brain, there will undoubtedly be a significant number of people who will still have the ischemic stroke, which is where there's furring up and the plaque ruptures and suddenly you get a stroke. And in that sense, that first type of stroke that I described should be thought more like a brain attack, as analogous to a heart attack, because that's how heart attacks happen. Heart attacks happen because suddenly plaque ruptures and the blood vessel blocks off. Similarly, strokes should be, that kind of stroke should be thought of as a brain attack, and people with atrial fibrillation can still have brain attacks. So that's a little bit about how you minimize your risk of strokes. The second question is, how do you calculate your risk of strokes? And that can be done by a scoring system known as the CHADS-2-VASc scoring system. I'll talk you through this, okay? Initially, they used to calculate the risk of stroke by something called the CHADS-2 system. CHADS, I'll tell you what that stands for. C stands for congestive heart failure. H stands for hypertension, high blood pressure. In brackets, it does not matter whether it's treated or untreated, close bracket. A stands for age, above 75. D stands for diabetes. And S2 stands for previous stroke or mini stroke. And the 2 stands for 2 points. So if you had any of those things, i.e. if you had heart failure, congestive heart failure, if you're above the age of 75, if you were diabetic, all those things would get 1 point. And if you'd had a previous stroke, you'd get 2 points. And that's how you calculated the risk of stroke. And most people would say that if you scored more than 2, then your risk was high enough to justify anticoagulants. Later, they started realizing that actually the CHADS-2 system seemed to underestimate the risk of stroke in people who didn't score very highly. So people who scored low on the CHADS-2 system were still at a much higher risk of stroke. And therefore, the CHADS-2 system was modified to something called the CHADS-2-VASc system, in which they changed the variables slightly. So now what they say is the CHADS-2-VASc system, C stands for congestive heart failure, H stands for hypertension, i.e. blood pressure. Age has now been lowered, so you get a point if you're above the age of 65, and you get 2 points if you're above the age of 75. Remember, in the old system, it was only above 75. D is for diabetes. S, 2 is for previous stroke or mini stroke. VASC is for the presence of vascular disease, another new addition. And then there's a sex component as well. So if you're a female sex, you get 1 point. So now you see people who scored 0 on the CHADS-2 system can now actually, the same people would be scored as possibly 3 on the CHADS-2 VASC system. So for example, if you were 66 and you were female and you had vascular disease, but you didn't have diabetes, hypertension, previous stroke, then you would have scored 0 on the CHADS-2 system. But on the new system, you would score 3 because now you're female and that's being incorporated in the new system. If you're above the age of 65 as opposed to 75, you get another point. And also if you have vascular disease. So the CHADS-2 VASC system is a lot more representative of stroke risk, particularly in those people who used to score low previously. And that is why it's always worth having your stroke risk calculated by your doctor using the CHADS-2 VASC system. And most people would say that if your CHADS-2 VASC score is above 1 if you're a man and above 2 if you're a woman, then you should be anticoagulated. And if you're anticoagulated, you should be anticoagulated for life, all right? Because your risk can only ever go up, because you can only ever grow older. You can only ever have diabetes. You can't have it and then it disappears. So you can, so it's worth bearing that in mind, okay? So the first thing is, yes, atrial fibrillation causes strokes. 2, of course, most people worry about embolic strokes, but they can still get those ischemic strokes or brain attacks I've told you about. Number 3, your risk is conferred upon you by your CHADS-2 VASC score. And if your risk is considered high enough, you should be anticoagulated for life, okay? One other interesting point I wanted to mention is that a lot of people say to me, well, you know, I have atrial fibrillation which comes and goes. I have paroxysmal atrial fibrillation. Has that got the same risk of having a stroke as opposed to having persistent or permanent atrial fibrillation, where I'm in atrial fibrillation all the time? And most of the studies and the guidelines say that, well, if you have paroxysmal atrial fibrillation, your risks are almost the same as if you have persistent atrial fibrillation. So it doesn't really matter whether your atrial fibrillation comes and goes. If your CHADS-2 VASC score is high enough, then you should be anticoagulated for life, regardless of whether your atrial fibrillation comes and goes or whether your atrial fibrillation is there constantly. Some people say, well, look, is there no correlation between the burden of atrial fibrillation that I'm getting and my stroke risk? So if I'm getting 30 seconds or a minute of atrial fibrillation, does that mean I have the same stroke risk as someone who has, you know, continuous 100% atrial fibrillation? And that's an interesting question because, you know, we as doctors sometimes see people with very short-lived runs of atrial fibrillation, you know, a minute or 2 minutes, and we don't know what to do about that because, of course, you worry that they have atrial fibrillation, but at the same time, you're going to give the patient a medication, an anticoagulant for life based on that. And anticoagulants carry the risk of causing bleeding. So you don't want to do this lightly. You don't want to subject a person to lifelong anticoagulation just because you've seen a little bit of atrial fibrillation. And this is a common question that people ask, you know, does the burden of atrial fibrillation matter? And I was looking this up and I wanted to share an interesting study with you. Of course, it's very difficult to try and answer this question, because atrial fibrillation can often be silent. So the patient, you can't just go by what the patient tells you. You can't say, if the patient says, well, I had 2 hours of atrial fibrillation yesterday because I felt my pulse go irregular. That's true, that's reasonable, but you can't be absolutely sure that it was just 2 hours, because sometimes you can get atrial fibrillation which is silent. The patient may not notice it. So you can't reliably base your decision making on what the patient tells you. So there was an interesting study where they looked at a much more accurate way of assessing the burden of atrial fibrillation. And the way you can assess the burden of atrial fibrillation much more accurately is in those people who have pacemakers or devices already implanted within their chest wall. So pacemakers, defibrillators, etc. And the idea behind that is that these machines can detect atrial fibrillation even if it is silent to the patient, with a great deal of accuracy. And they can give you a very, very accurate estimate of the burden of atrial fibrillation. Okay, so there was an interesting study, an observational study. This was published in 2009. It was called the TRENDS, TRENDS, TRENDS study. And the idea behind the study was that they wanted to see whether the burden of atrial fibrillation that they were picking up in people had any correlation with the risk of stroke. Okay, and what they found was that they measured the burden, and they found that actually there were three groups. There were those people who had no atrial fibrillation, and in those people, that doesn't mean they in the past month. Okay, in the past month, in 1 month, they had no atrial fibrillation detected on the device, and they had a very low risk of strokes. Then there was another group which had, in whom you did pick up some atrial fibrillation, but the burden was less than 5.5 hours in the preceding 30 days. In 30 days, the burden was less than 5.5 hours. In those people, the stroke risk was still low. But then there was a third group who had more than 5.5 hours of atrial fibrillation in the 30-day in a 30-day period, and they had a substantially higher risk of stroke. So having more than 5.5 hours of atrial fibrillation in a 30-day period almost doubles your risk of stroke. So if the question is, does my burden matter? Yes, the burden matters. How much AF is enough to justify the anticoagulation long term? Well, the answer is 5.5 hours. Who is this going to be useful for? Particularly those people who have devices in place already, because in those people you can measure the atrial fibrillation burden. So if you already have a pacemaker in, and then you're told, oh, well, we've picked up some atrial fibrillation, and you're worried as to what that means for you, then of course the one option is just to go on an anticoagulant. But if you're a little bit concerned about going on an anticoagulant, then the 5.5 hour burden in the preceding 30 days is a good marker, because if you've got it, then that means that your risk is higher than if you don't have that. So I hope this was all useful and answers some questions. Please feel free to drop me a line, send me some messages about any other questions you'd like me to try and research and answer for you on atrial fibrillation. I'll just add in my website. This is my website, yourcardiology.co.uk. This is my Facebook page. And this is me. So thank you so much once again. Thank you for all your support. Thank you for all your kind words. I really, really appreciate it. And I wish you a good night. And thank you for the birthday greetings. Bye.